All right, let's jump straight into this explainer. We're going to break down the high-stakes, incredibly time-critical clinical reasoning behind managing solid organ and retroperitoneal trauma, and we'll be doing it through a series of rapid-fire, case-based vignettes. If you've ever wanted to get inside the mind of a trauma surgeon making split-second decisions with the clock ticking, you are absolutely in the right place. We're going to use these clinical questions to really unlock the core, non-negotiable principles of trauma management.
Our agenda today covers four main areas: splenic trauma triage, biliary and pancreatic injuries, retroperitoneal duodenal signatures, and finally, renal trauma management.
Starting with Section 1, Splenic Trauma Triage. Let's see how early clinical observation can turn on a dime.
Okay, picture this. You have a patient resting comfortably on day 2 after taking a massive blunt impact to the left upper quadrant. Everyone is breathing a sigh of relief, right? But then, completely out of nowhere, their blood pressure absolutely plummets and their heart rate skyrockets. So what are we dealing with here? Is it A, a delayed renal injury, B, decompensated shock, C, a colonic injury, D, a delayed splenic rupture, or E, distributive shock?
The correct answer is D, delayed splenic rupture. What's actually happening under the surface here is that an initial subcapsular hematoma, or maybe a protective perisplenic clot, is slowly expanding. Over hours, or sometimes even days, that increasing pressure finally causes the splenic capsule to give way. The result? A sudden massive hemoperitoneum. You need an immediate bedside fast scan to catch this rapid hemorrhagic shock. And here's a massive clinical pearl for you. While hepatic rebleeding usually happens within the first 48 hours, a damaged spleen can totally trick you and rupture days or even weeks after the initial impact.
So, moving to our next question, we love to observe a spleen without surgery if we can, but what imaging finding completely throws that conservative plan right out the window? Which of these is a strict contraindication to just watching and waiting? Is it A, a non-expanding hematoma, B, hemodynamic stability, C, a CT scan showing active bleeding, D, a hematoma involving 20% of the surface, or E, a grade 1 injury?
The answer is C. An arterial blush, which is active contrast extravasation on a CT scan, demands immediate action. Listen, even if your patient is sitting up in bed, chatting with you, and has perfectly stable vitals, that arterial blush means they are actively bleeding straight into their abdomen. Observation is a guaranteed failure here. You have to get them to interventional radiology for transcatheter angioembolization. You typically have a strict 12-hour window to get this done, but the second they start dropping their pressure, you've got exactly 1 hour to intervene. No exceptions.
This brings us to a really fascinating contrast in management. Take a look at the pediatric case. A hemodynamically stable kid with a low-grade tear gets strict conservative observation. We do this because we absolutely want to preserve their spleen to protect their developing immune system from overwhelming post-splenectomy infection, which is usually caused by strep pneumonia. But then look at the adult case. An avulsed splenic hilum? That is catastrophic. The hilum is where all the major vessels enter the organ, so you literally cannot stitch that up. A splenaraphy is completely contraindicated. You have to do an immediate total splenectomy to keep the patient from bleeding out on the table.
Let's move into Section 2, Biliary and Pancreatic Injuries. We're going much deeper into the abdomen now.
Time to test our surgical planning. Imagine a knife blade causes a clean, partial cut right across the common bile duct. How do we physically reconstruct that tiny, delicate lumen without it scarring shut or leaking bile everywhere? Are we doing A, an end-to-end repair over a T-tube, B, a hepatocogyginostomy, C, a cholecocyginostomy, D, ERCP and stenting, or E, just intubation of the duct?
The correct answer is A. For clean, sharp cuts with minimal tissue loss, you do a primary end-to-end repair right over a T-tube. That tube is absolutely crucial because it acts as an internal stent to keep the duct open, and it diverts the bile safely away from your fresh sutures. But notice how this changes for complex injuries. If a gunshot wound obliterates that same duct with extensive tissue loss, you can't just stretch the ends back together. You have to do a major bypass and bring up a loop of bowel for a Roux and Y cholecocyginostomy.
Before we tackle pancreatic mortality, you need to know this vital physical clue: the pathognomonic imprint sign. When you see a distinct bruising or depression right in the middle of the upper abdomen, the epigastrium, it's visually telling you that a massive blunt force, like a steering wheel, has crushed the retroperitoneum directly against the spine. And guess what sits right in the crosshairs of that impact? The pancreas.
So given that immense crushing force we just talked about, what actually drives early mortality in these patients?
If a patient with that imprint sign collapses and dies quickly, is it A. sepsis, B. a duodenal fistula, C. a perforation, D. a mesenteric tear, or E. hemorrhage from associated vessels?
The answer is E. Here's the twist. It's rarely the pancreas itself that kills the patient quickly. It's catastrophic hemorrhage from the adjacent major vessels. Because the pancreas is nestled right up against the aorta, the inferior vena cava, and the mesenteric arcades, a force strong enough to crush the pancreas will almost certainly tear those massive vessels. Isolated pancreatic injuries actually happen in less than 10% of cases. Now, if they survive that initial hemorrhage, then delayed mortality is driven by sepsis from the leaking pancreatic juices. Also keep this in mind. Initial amylase and lipase blood tests can be completely normal right after the trauma, so do not let normal labs give you a false sense of security.
But what if we do have direct, severe damage to the pancreas itself? Let's say there's a penetrating injury to the body of the pancreas, located to the left of the superior mesenteric vessels, and the main pancreatic duct is completely severed. What's the optimal surgical move? A. Drainage alone. B. A Ruiguino Y. C. A Whipple procedure. D. A Frey procedure. Or E. A distal pancreatectomy.
The answer is E. Because the duct is completely severed, we can't just leave a drain in there and hope for the best. We have to perform a distal pancreatectomy. By removing the tail of the pancreas, which is all that tissue distal to the tear, we are literally saving the patient's retroperitoneum from being aggressively digested by their own highly active pancreatic enzymes. Leaving that devitalized tissue in place is a guaranteed ticket to severe chemical autolysis, abscesses, and massive fistulas.
Moving on to Section 3, retroperitoneal duodenal signatures. This is easily one of the most challenging diagnostic areas in trauma surgery.
Imagine a patient comes in after taking a heavy punch to the abdomen. A plain X-ray mysteriously reveals a halo of air completely surrounding her right kidney. Which organ has ruptured to cause this highly specific, frankly bizarre finding? Is it A, the rectum, B, the duodenum, C, the stomach, D, the descending colon, or E, the cecum?
The correct answer is B, the duodenum, and this perfectly illustrates why. A transmural tear, meaning a complete perforation of the duodenal wall, leaks luminal gas directly into the retroperitoneum. That gas tracks right along the fascial planes and outlines the right kidney, often completely blurring the psoas muscle shadow. This is so different from a duodenal hematoma, which you can see in the second column. A hematoma is just bleeding under the mucosa. It doesn't leak gas. Instead, as the blood expands inward, it squishes the bowel lumen, creating this classic coiled spring or stack of coins appearance on contrast imaging.
So, how do we definitively find these sneaky duodenal injuries when plain X-rays just give us hints? Because the duodenum hides so incredibly deep in the back, bedside fast ultrasounds or peritoneal lavages are virtually useless. They just can't see past all the overlying bowel gas. We have to rely strictly on an emergency, high-resolution CT scan, and importantly, we use both IV and oral contrast to catch that retroperitoneal leak. Also, a huge warning here. Never, ever order an endoscopy in acute trauma. Pumping air in to see what's going on will just blow the existing perforation wide open.
Finally, Section 4, renal trauma management. Let's shift laterally to the kidneys and look at the rules of non-operative care. Here is a super classic scenario. You have a patient with a bruised, hematoma-surrounded kidney after blunt flank trauma, but their vital signs are absolutely rock solid. What is our next surgical move? Do we go for A, percutaneous aspiration, B, observation, C, a laparotomy, D, a nephrectomy, or E, endovascular repair?
The answer is B. We literally do absolutely nothing invasive. Over 90% of these stable blunt renal traumas require strict observation. The human body is just amazing at healing itself here. We put them on strict bed rest until the gross blood clears from their urine. And whatever you do, do not aspirate the hematoma. Poking a needle into it only invites infection and disrupts the natural life-saving tamponade that the clot is providing. Just watch them closely, check their blood counts, and later down the road, you absolutely have to monitor their blood pressure for delayed gold blood hypertension, which is caused by renal scarring.
This explainer leaves us with a chilling but vital truth. In trauma surgery, the most lethal threats are often the ones you can't immediately see on the surface. Understanding these deep anatomical signs, knowing exactly when to rush to the OR for an arterial blush, and when to sit firmly on your hands for a stable kidney hematoma, is absolutely critical to keeping your patient alive. Keep these physiological signatures dialed in, and you'll always be one step ahead of the bleed. But honestly, it makes you wonder, as imaging technology gets even more unbelievably precise, how many more hidden surgical signs are we about to uncover in the next decade?